Okay, we begin again with diseases of the venous circulation, and we're going to start talking about venous thrombosis, and this is slide 114. A thrombosis, or thrombosis, or is the same thing as a blood clot. And a venous thrombosis is a blood clot, obviously, in the vein. That's where it would be. And it develops in the superficial or the deep veins. And we have what we call a deep vein thrombosis, or a DVT. And these can be life-threatening. The risk factors for venous thrombosis include conditions that cause venous stasis, which means, the vein may get kind of hard. It may not be flexible to move as needed. Hypercoagulability, and this is when your blood coagulates too much. It doesn't stay at medium consistency. It gets really thick, and obviously that thickness can cause clot. And then any kind of vascular trauma. Older adults are especially prone to deep vein thrombosis or any kind of thrombosis, mainly during post-surgical things like a knee replacement or a hip replacement. They can throw a clot really fast, and that can be dangerous for them. And sometimes it may even cause them, if it's like a knee or hip, it could even cause them, especially a knee, to get their leg amputated if they do throw a clot. If they're not moving around right after surgery, that can cause blood clots, and of course decreased blood flow. And then it can also cause the blood to pool in the lower extremities, which if blood is pooling and sitting there, then it will coagulate and cause a clot. It's not associated with symptoms in about 50% of patients. But if you do have signs and symptoms, we have like an inflammation of an area. It may be hot to touch. It could be swelling. You may have deep muscle tenderness. All of these are indications of blood clot. So how do we treat it? What do we do? The early detection, of course, is the best, and prevention of clots. It can become an embolism. An embolism, a clot is attached to the vein wall, and embolism is when the clot breaks off and starts moving, and it usually will move to the lungs or the brain, and you can be killed just like that. So early ambulation after surgery or childbirth is a must. Exercising your legs, use of compression stockings. These are stockings that they put on people in the hospital to keep the blood flow moving up and down the legs. So all of these can help thrombus formation. So to remove it, we're going to try use blood thinners at first. And if it gets severe enough, we'll have to perform surgery to remove the blood clot or the embolism, whichever one it is. Okay. Let's talk about varicose veins and spider veins. Look on page, let me make sure I'm in the right area here. Varicose veins on page 123. These are dilated, distorted veins, and if you look at figure 613, this shows you spider veins. Not quite the same, but varicose veins are those big veins that look like big lumps right under the skin. So these are dilated, distorted veins, usually forms in the superficial vessels of the leg. The most common vessel is the greater saphenous vein. Okay, so make sure you highlight that or remember that. Symptoms of this, usually none, unless they become, large and you may have some swelling and tenderness with it. You could have like a knottiness under the skin, so it really just depends. Varicose veins can be an occupational hazard, so if you are prone to these, then you need to wear stockings under your uniform or your clothes, whatever you wear to work, to make sure that the varicose veins don't form. What we can do for legs that are prone to that is we can, what we say, like a milking movement. We can just kind of rub them up and down to make sure blood is flowing and not pooling anywhere. Because as I said before, pooling can cause blood clot, and of course it can cause your varicose veins. Pregnancy and tumors in the uterus can cause varicose veins. So sometimes we're not just treating the vein, we need to see if there's an underlying cause. And if you look in figure 613, under the spider veins, you can see some large, lumpy varicose veins as well. So make sure you look at that real close. Complications, it can get infected and it can ulcerate, so we have to be really careful. And the reason it ulcerates is because there's poor circulation there, and if blood is not flowing correctly, the tissue will die, and that causes necrosis or ulceration of the tissue. It can also hemorrhage as well if we accidentally nick it while we're shaving. So treatment is usually, very beginning we're going to do the bandaging or compression stockings or something like that, very minor. If it gets more severe, we may have to strip and do a strip and ligation of the veins. So let's talk about spider veins. Again, in figure 613, this shows you the spider veins. These are small, dense network of capillaries, or veins that appear red or blue. The cause of spider veins is unknown. Some people think it is hereditary. It can appear more in women, it seems like, than men, but men, of course, can definitely get them as well. Hormones, like during your pregnancy, during a period, your menstrual cycle, during menopause, stress, all of these things have been not proven, but are likely to cause spider veins. For spider veins, we can do compression sclerotherapy, and this is where we have a strong saline solution that's injected into the veins to try to open up the vein and make it disappear from under the skin. And that can be pretty painful to do, but it's a pretty good treatment for it. Alright, let's go on. I think the PowerPoint skips a little bit, but we want to go to chronic venous insufficiency on page 124. This is known as CVI, and it's poor venous circulation. Basically, it doesn't return blood to the heart. This can cause thrombosis or blood clot. So this is like your deep vein thrombosis. So to diagnose this, we can do a medical history. We'd see if the patient smokes, if they drink, obesity, there may be family history, pregnancy is a big cause, of post-surgery. So what the definitive diagnostic test for a deep vein thrombosis is going to be your Doppler ultrasonography, and it's just like a little wand that they put on the leg and look to see where the clot is. It can show you the veins and everything, and that's the definitive diagnostic tool. Signs and symptoms of a DVT are throbbing pain, maybe have a fever or hotness to it, swelling, loss of feeling. It may cause some blood flow issues to the extremities. And then as it gets worse, venous stasis may develop. A venous stasis can cause venous stasis ulcers, which that is a very severe case of a DVT. So risk factors is age, of course, post-surgery, let's see, family history of DVTs, sedentary lifestyle, obesity, and smoking those are all causes and risk factors for DVTs. Treatment is going to depend on the disease. We can try to start with stockings or elastic bandages to try to prevent it, and then or help it. And then sometimes we have to do a surgical repair. And this again is stripping and ligating. And what they do is they do an incision below the vein, then they add a flexible instrument into the vein, it's threaded up the vein, and then the vein is grasped and removed. And that is a good treatment for it. Now, going on to the next part, venous thrombosis. Venous thrombosis. A clot, that's the same thing as a blood clot. This can develop in superficial arteries or deep arteries, so it all just depends. It usually happens in the lower extremities, just like our DVTs. The risk factors are going to be the same. You know, if you have hypercoagulation of the blood, which means that your blood is thicker than normal due to post-surgery, could be family history, smoking, alcohol, all of those can be risk factors. Usually there's no symptoms with venous thrombosis. And then we already talked about an embolus, where the clots can detach and become an embolus. Okay, now let's go back to the PowerPoint on slide 120 to coronary heart disease. This is a very common condition of the heart, and this is the main cause for myocardial infarction. Coronary heart disease supplies, the coronary vessel supplies the heart with blood and oxygen. It serves the heart muscle itself, and again it can cause heart attacks because of the blockage of the coronary vessels. Let's see, vessels they become occluded and blocked, and if this is the heart right here, they kind of wrap around, so they provide oxygen to the heart. So what's going to happen, these coronary vessels are going to narrow, the lumen of the vessels, which is the inside, they're going to narrow, and this is called atherosclerosis, like we already talked about. Ischemia, we've talked about that, is a deficiency of blood supply and obviously oxygen supply to an area or organ. So we can have like a little ischemia going on there. If ischemia continues, it can result in a heart attack, because when the myocardium, which is the heart muscle, is suddenly deprived of blood due to occlusion, then it's going to cause tissue death or necrosis, and this is called a myocardial infarction. That's a heart attack. So let's go on and talk about, before we talk about angina, angina pectoris, which is what your PowerPoint talks about, I want to talk about some of the symptoms of a myocardial infarction. Of course, you'll have the shortness of breath, you'll have heart palpitations, you may have bradycardia or tachycardia, which is slow or fast pulse. You could, the most common thing, chest pains that radiates down the left arm. So now let's look the difference and see the difference between a myocardial infarction and angina. So angina is temporary chest pain, okay? It could just be transient oxygen insufficiency. We can't get enough oxygen. And usually we have pain below the breastbone, and it can radiate to the neck, jaw, and arm, so it does feel very much like a heart attack. You may feel some tightness and suffocation. Now, the main thing I want you to know here is the difference between angina and myocardial infarction. If somebody is having a heart attack, their pulse and their heart rate is going to change. With angina, their heart rate will not change. So that is the difference between the two. Angina can be triggered by physical activity, it can be triggered by certain medications, eating a lot, exposure to cold, over-emotional stress, and usually if you just kind of rest and chill out a little bit, it'll go away. So treatment for angina, which is the same thing as chest pain, is nitroglycerin. That's the most common thing we use, and we call these nitro pills, and you put them under the tongue, which is sublingual, whenever you feel any kind of chest pain coming on. Alright, now if somebody has unstable angina, this is when we have recurring attacks of the chest pain that radiates to the arm. So when we have this, we have to really control our exercise, control our physical activity, and seek the doctor, because it could be a warning sign to something else. So symptoms of this is going to be severe chest pains, and then let's see, restlessness. You may have some nausea and vomiting with this, clammy skin. So very similar to a heart attack. The prognosis for myocardial infarctions and angina, which is kind of a part of it, but prognosis is, depends. Usually the patient will code, that's what we call it, and we have to do CPR. When they code, that means their heart stops, they stop breathing. So, it just totally depends on how fast treatment is started. Women are especially prone to heart disease, and it's harder to find in women because our coronary arteries are a lot smaller than men. So women have to take special precautions, especially after a heart attack, because within 1 year after a female has a heart attack, almost 40-45% will die after the first heart attack, and men are about 25%. So women have to be especially careful. To diagnose and the severity of an MI, we have to look at the size of the occlusion, and we're going to try to remove it, and the distance from its origin, and this will tell us how much heart damage has been done. Enzymes found in the blood, we have to do a test called a CPK enzyme test, and that can tell us how much damage has been done to the heart muscle. Let's see. Let's look and talk about myocardial repair. Myocardial repair, obviously you're going to have a lot of scar tissue from all the necrosis that's been going on, so your heart may have a limited function. It's not going to be functioning as normally. You can be more at risk for clots because of that. So we have to control our exercise to maintain circulation. Your strength may be limited, and so risk for any type of coronary artery disease, again, are obesity, hypertension, smoking, sedentary lifestyle, high cholesterol. So those 5 things are the main risk factors. Treatment for heart disease. If you've had one heart attack, usually if there's a lot of severe damage that's been done, the treatment is not very good. We can't really do a whole lot. We can do some drugs, but that's really about it. And if we get it 3 hours after the attack, the prognosis is a lot better. Anticoagulants will be used to keep the blood thin so clots will not form. An aspirin a day, a baby aspirin a day, which is 81 milligrams. Coumadin is the most common type of anticoagulant, so that is the one that's going to be used mainly for the patient that may be more prone to blood clots. The patient may have to have a bypass, coronary artery bypass, which is a surgery, and basically the physician will go in and take the occluded part of the vein out and sew the good parts of the vein back together. And it's used to obviously reroute blood. I'm sorry, not the coronary vein, the femoral arteries, the saphenous vein, not the coronary vein, my bad. We can do the angioplasty, the cardiac catheterization, where we go in, balloon angioplasty, we go in with a catheter, inflate the balloon, and it breaks all the plaque up. So that can happen. Okay, I think we will go on to myocardial and endocardial diseases. We're going to start with infectious, I think we're going to start that. Actually, we're going to start on page 127 and talk about myocarditis. This is any kind of heart muscle disease, okay? Inflammation of the heart muscle. The main thing that's going to cause this is certain viruses, mainly the Coxsackie virus, Coxsackie. The adenovirus can cause it, and the echovirus, but the Coxsackie is usually what we find that causes heart disease. People that have HIV and AIDS are going to be very common to develop myocarditis. So to diagnose myocarditis, we can do an EKG, we can do an echocardiogram, we may do blood cultures to see the virus count and see what virus it could be. Blood cultures, heart levels, those heart enzyme levels. So signs and symptoms of myocarditis are none usually. It's usually asymptomatic, but you may have a history of viral illnesses. You could have HIV or AIDS, pain, fever, chills. You may have a shortness of breath or have some shortness of breath or a rapid heart rate. So treatment for myocarditis is to prevent further disease from happening to the heart. So we can bed rest, keep the activity restricted. Antibiotics may help. If it's a virus, antibiotics don't really kill viruses, but if there's any other thing like a bacteria that's been seen, we can do antibiotics to try to kill the bacteria. Going on to cardiomyopathy, this is a functional disease of the myocardium. So there's three types we're going to talk about. The first type is dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. And then we have actually four types: idiopathic cardiomyopathy. So let's go to dilated cardiomyopathy. This is the most common form, and it's a dilation of the ventricle. It causes a contractile dysfunction, and you may have symptoms like that are comparative to congestive heart failure. The hypertrophic, restrictive cardiomyopathy is the least common form, and it's associated with reduced heart filling pressures and endocardial scarring in the ventricle. Then we have idiopathic dilated cardiomyopathy, so we don't know what the cause is for this. The symptoms of this are going to include dyspnea, painful or shortness of breath on exertion. We may have orthopnea, meaning when we change positions, certain positions may make us shorter breath. Weakness, fatigue, ascites, which is fluid on the abdomen, and peripheral edema, which is edema or swelling in the extremities. So treatment is going to be to relieve the symptoms. That's really all we can do. Alright, let's go on to diseases of the endocardium, and we're going to pick up in the PowerPoint with slide 143. Infectious endocarditis is due to some kind of bacteria or virus. It's inflammation of the endocardium, which is the inside lining of the heart muscle, caused by a strain of Streptococcus, which is strep. Organisms will enter the bloodstream from various routes that you can get it from, and then what happens is we get nodules on the in the endocardium, and these nodules can become emboli and detach themselves and go to the lungs or the brain and be very, very dangerous for the patient. Let's see, rheumatic heart disease on page 129. This is also due to a virus like rheumatic fever. That's the most common cause of rheumatic heart disease. Rheumatic fever is a autoimmune disease, and this is usually from a strep infection. that's gone untreated. So it starts affecting the mitral valve and the aortic semilunar valve, and it causes rheumatic heart disease. The valves, what they do is they become very swollen and inflamed from the infection. You may have some blood clotting going on, and then blood starts flowing over the valves instead of through the valves. So these little nodules that we call vegetations that are on the endocardium are along the edge of the cusp. So the cusp are not working like they should, and they thicken. The cusp will thicken and start sticking to each other and not function whatsoever. If the adhesions on the cusp seriously narrow the valve opening, we'll have the mitral valve, it'll become stenotic, meaning it'll stay very narrow and frozen. It won't go open and close like it's supposed to. So that's what we call stasis, is the inadequate flow of blood from the left atrium to the left ventricle, and that's called stasis, or slow blood flow. And this can cause blood clots. We may also have an insufficient valve, which means the valve may not close all the way. The valve usually opens all the way and closes all the way. And so in insufficiency, the valve, is leaving us a little space so blood can regurgitate, which is not good. Rheumatic fever and heart disease is not very common today. We've kind of gotten rid of that through vaccines, and being able to treat strep infection mainly with penicillin. Alright, we're going to stop there and pick up with the next section in valvular heart disease.